you're very welcome. Damien O'Dowd is my name. And you're welcome to the first of the 2025 public lecture series here, Trauma, What Does It Mean for Mental Health, which will be delivered by Dr Louise Canacott. St John Hospital is committed to raising awareness and reducing stigma around mental health through our initiatives such as the public lecture series. And also we deliver mental health first aid training through Mental Health First Aid Ireland. Tonight's lecture will take approximately 45 to 50 minutes. It'll be followed by a short interval, during which time the questions sheet that you would have found on your chair will be collected by a member of our team and will be given to the panel for the question and answer session afterwards. We plan to finish at approximately 9 p.m. Our event tonight is being live streamed and will be available through our website in the coming days. So before we commence this evening's proceedings and I hand over to our chair, Fergal Rooney, I just ask people to either turn off or just silence their mobile phones, please. In the event of an emergency, the exits are to the right or the left when you go through this door here. The left takes you back down to the main reception where you would have come in. And also in terms of toilet facilities, they're past the main reception and turn left at the next set of double doors. We hope you find this evening's talk beneficial. And it's my pleasure now to introduce you to our chair tonight, Mr. Fergal Rooney. Fergal is head of our psychology department here at the hospital. Thank you.
And a very warm welcome to all of you. I just will keep my comments very brief as we start proceedings this evening. But I want to introduce my colleague, Dr Louise Canacott, who is going to be presenting our topic tonight. Louise is simply an amazing psychologist. She's proven herself in the UK to be an extremely competent and influential psychologist, working largely in young people's services as a clinical and forensic psychologist. And work of that variety is going to guide anybody into considering how does trauma impact on the well-being of a person. And Louise certainly has embraced that in her own practice and has evolved her practice to ensure that she delivers the most appropriate and best of services to the people she meets. She has been extremely influential here in the hospital since she arrived with us a few years ago, in terms of just helping us to become ever more mindful of the importance of delivering trauma-informed practice as a core tenet of how we operate in the hospital. As you may be aware, national policy around mental health really instructs us and guides us to consider trauma as being right at the core of how we understand and engage with people to support them through mental health difficulties. So I think the topic tonight is very timely and no doubt you'll find it very interesting. I would say as we set off that trauma is one of the sneakier elements of our lives. It is something that can be present for many of us, sometimes in a sleeping kind of a way. In fact, there's a very important thinker in this whole area, Bessel van der Kolk, who said that trauma comes back as a reaction, not as a memory. So the very thing that may have caused us quite a difficulty, or layers of things that may have caused us difficulties, may not be to the front of our brains. And we can be triggered into being brought back to that point in time. And I say that at the start of our talk tonight to encourage all of you, whether you're here in the room, and I know there's many people who are tuning in online tonight, to just practice a little bit of self-care with yourself. Mind yourself. If you notice that you're being prompted to remember certain things, or if you notice a reaction in yourself, please do be gentle with yourself. Don't push yourself or expect too much from yourself, because the nature of what we're talking about tonight relates to us all, whether we fully grasp that or not in the moment. So please be careful and please be gentle. So without anything further to say, I want to pass you over to Louise and to welcome her to make her presentation to us tonight. Thank you, Louise.
Thank you. Thank you, Fergal, and welcome everybody. I hope you're all able to hear me okay. Yeah, if not, there's mics that I can grab if needed. So yeah, you're all very welcome for this talk on trauma today. So Fergal has already given us a bit of a instruction around minding ourselves. So this may not be the correct one. So this is the outline of what we're going to discuss. We're going to start off probably what most of you would expect, so giving an overview. And then we'll think a little bit about what are common reactions to trauma. So what would we expect most people to experience after a traumatic event? And then we'll spend time thinking about what are the effects of trauma. So these are wide-ranging effects. So that will be kind of the core of the presentation. And then we'll think at the end about what does trauma treatment involve. So there'll be time at the end of all of that if people have particular questions. You do have the paper beside you, so throughout, if there's anything that you'd like me to clarify at the end, or if you do have any particular questions, just jot those down as we go, and we'll do our best to get to as many as we can in the time. Okay. So Fergal has already helped us think about this a little bit, but just to reinforce that point that what we're discussing might be difficult for people, and in the interest of trauma-informed care, please do what feels necessary for you, if that's taking a moment to yourself, if you're stepping outside of the room, whatever feels best for you to be able to get the most of the talk. So what is trauma? I suppose most of you coming here today had some idea, which is what maybe has brought you in thinking about what is the topic that we're going to cover today. So lots of different definitions out there about what trauma is, and so we'll go through some different ideas. And throughout the presentation, I've referenced some books which are really accessible and cover aspects of trauma in different ways. So the first one there, What Happened to You, written by Bruce Perry, who's been very influential in understanding trauma, particularly in childhood. So traumatic responses occur when we experience stressful, frightening, or distressing events that are difficult to cope with or are out of our control. So the sense then is that the event that we're faced with is something which is very large and very difficult to manage. But trauma is not the event itself, but rather it's the emotional response to the distressing or disturbing or overwhelming experience or set of experiences. So I think separating that out, that it's not the particular event, it's what this creates in us as a result of the event. So the lasting impact that this event or set of experiences has on us in terms of our functioning, our thoughts, our feelings, but also on our body. And we'll go on to think about that a little bit more. So trauma comes from the Greek word for wound, and I think when we think about it this way, it's helpful to separate out. It's not what happens to you, it is what happens inside of you as a result of what happens to you. So as Gabor Mate has said, if anyone hasn't come across him, another really influential person in the field of trauma, it's not the blow to the head, but the concussion I get. So if we think about what is left within us after the traumatic event. And when we think about it that way, it's hopeful because we can't change the event itself. We cannot change what it is that has happened, but when we have our own reactions that we're left with, perhaps there's something that we can do with that. So this makes trauma a subjective experience, so it's in the eye of the beholder. And that can help us understand why two people who experience the same event may have very different reactions. So the way in which each individual has made sense of that experience can help us understand different reactions. So I think some of this is explained a little bit more in this book that I referenced here. But it's important to note that although two people can experience the same event very differently, that is not to say that it is anybody's fault. our brains and our bodies do what they need to do during traumatic events to help us survive. So essentially, trauma can be viewed as any event that infringes upon an individual's sense of control and is beyond a person's ability to manage at the time. So what types of experiences can be traumatic? So trauma can include events or experiences where you feel frightened, under threat, humiliated, rejected, abandoned, invalidated, unsupported, helpless, unsafe, trapped and neglected, amongst many others. And so when we lay things out like that, it's not unreasonable to consider that many of us in our lives might have experienced different types of events like this. And in that sense, trauma is not uncommon. So in a recent piece of research done in 2020 in Ireland, about 82% of Irish people said that they had experienced at least one traumatic event. And about 67% said that they had experienced at least two. So trauma can result from one-off or ongoing or repetitive experiences or events. So we can separate these out. So sometimes there is a single event that can occur, and in other times there might be something more repetitive, more enduring that somebody is experiencing. It can mean that somebody has been directly harmed or neglected, or they may have witnessed harm to somebody else, or they may have learnt about the harm that somebody else has experienced. But also living in a very traumatic atmosphere, or in an atmosphere that had experienced trauma in the past, even that happened before you were born. So we know that there is evidence to indicate that even before a child is born, if there's trauma experienced in the mother's life, there's vulnerability in the child. So Fergal has mentioned Bessel van der Kolk there, and if anybody hasn't read this book yet, The Body Keeps the Score, another really brilliant piece outlining the role of trauma. So if we're thinking that 82% of people experience a traumatic event in Ireland, what types of events are we talking about? And we can separate these out. So we can distinguish between events known as big T traumas and little t traumas. So big T traumas are often the things which jump to people's minds when we think about traumatic events. So they are harmful things and hurtful events. Again, these could be single one-off events or repeated or ongoing events. And big T traumas are those types of events which most people would consider to be traumatic. So some examples. So incidents like war, accident, so whether that's a road traffic collision, for example, natural disasters, traumatic bereavements, sexual or physical assault in a one-off event. And then there are other events where there is repeated trauma. So examples include physical abuse, verbal abuse, sexual, emotional or psychological abuse. So reasonable to think that these types of events would have significant impact on the person experiencing them. And in Ireland, the most commonly reported traumatic event is learning of the death of a loved one in a really awful manner. So again, a single event trauma, a traumatic bereavement with long-lasting effects for many people. But then there are other types of trauma. So not everybody will experience the big T traumas, and it's often the big T traumas which people are encouraged to access support for. But there are many other types of experiences which can also be considered traumatic. So these might be not easily identifiable for people, and they may be more insidious over periods of time. So doesn't it result from a single event, but rather from a culmination of multiple experiences. So on their own, it may not be seen as traumatic, but rather an overwhelming experience, but perhaps multiple of those with culminating effects. And it's not just about bad things happening, but it can also be about good things not happening. So if we think perhaps a child growing up with core emotional needs which are not being met repeatedly. So core needs being the need to feel safe, the need to feel protected, the need for love, for nurture, for affection, the need to be accepted by other people, included. These are all core needs that children have. And so when they are not met, there can be impacts on mental health. So experiences of these are examples such as growing up and experiencing criticism, experiences of rejection, isolation, not being accepted, not being seen, and there's an erosion of self-esteem over time. So if somebody experiences a traumatic event, there will be a series of common reactions that we would expect most people to go through. So these are some examples of what we commonly come across following an incident of traumatic nature. So shock, numbness, feeling helpless, having disrupted sleep, a sense of fear, sadness, emotional instability, difficulty concentrating, irritability, intrusive images or memories, avoidance, or feeling on edge. So we'll go through some of these and just think about what that might look like. So commonly, if this has just happened quite recently, our body is trying to make sense of what has happened. And so in this sense, they're very normal reactions to very abnormal events. But when people are experiencing these, it can often feel very frightening, and there can be a sense that perhaps I've been changed forever. But for the majority of people, these reactions are short-lived. They occur, and for most people, over a number of weeks, we'd expect things to improve. Examples of these might include intrusive images, so maybe finding it very difficult to get memories of the event off your mind, perhaps images replaying, perhaps images popping into your mind even if you're really trying very hard not to think about them. When those happen, it might give a sense of being back in that particular event itself. So images that people find very distressing, and the unpredictable nature of those can make people feel quite on edge and quite unsafe. And there can be a huge emotional reaction to those too. Avoidance following a traumatic event is really understandable and really common. So again, if these intrusive images and memories are popping into people's minds, they're often highly distressing and really difficult. So commonly, it is normal to think that people would try their best not to think about these things. So maybe to try and push them away, or maybe to try and focus your mind on something else. And people can achieve that in all kinds of ways, and some of that can be helpful, perhaps being busy, or things like returning to work. Some of those things can be helpful to an extent, or people might try other ways to avoid thinking, so drugs and alcohol, for example, as a way of dampening down some of that experience. But avoidance can also be behavioural, so perhaps not wanting to go near particular places that might bring back reminders of the event, perhaps not feeling comfortable to see people where there's a risk that this topic might be brought up. So with that then, people's worlds, when the avoidance becomes quite entrenched, can become a little bit smaller. So for example, with a road traffic collision that might begin, not getting in the car to drive, that might then become perhaps not getting in the car as a passenger. Perhaps cars don't feel safe. Perhaps that part of the road no longer feels safe. And you could see how over time this avoidance can grow. Another very common reaction is feeling on edge. So a sense of adrenaline really going through the body, and a sense of alertness and perception that danger could happen anytime. And that's very challenging, because when people don't feel as though they're safe, our body finds it very hard to relax. So things like sleeping, feeling calm, being able to be present and engaged with people can be very challenging. And some of that can connect with some of the other emotions here, such as anger, irritability, if we're feeling very on edge. So as I said, the majority of people who experience those reactions will have a normal period of acute stress, and then they'll improve over time. So we'd expect a reduction in those, on a week-by-week basis. But for some people, they might persist, and that's really not as common in comparison to those who are able to recover from the traumatic event. So for some people, their symptoms will remain at a very high level, even following 4 weeks plus. And then we might be thinking a little bit more about symptoms which haven't resolved and are most likely creating a lot of difficulty for people in their lives. So we may have one group of people where the symptoms resolve over time, they follow this kind of trajectory. For others, there might be a symptom reduction, but they're still not back to baseline, and there might be some fluctuations. And then there might be another group where the symptoms remain very high and there's no improvement over time. And so some symptoms might continue, particularly the intrusive symptoms, so those kind of flashbacks or senses of reliving. If they're persistent, again, very distressing. The avoidance, and the hypervigilance and hyperarousal. So that is the sense of feeling very on edge, needing to scan to make sure that things are safe. You know, that sense of perhaps something bad could happen at any moment. So if those types of difficulties do persist, it causes huge effect for people in their day-to-day lives. So again, in that study, the Irish study in 2020, it was found that about 6% of people in Ireland would reach criteria for post-traumatic stress disorder. And many of those would have co-occurring mental health conditions such as depression or generalised anxiety. And it's understandable when we think about what some of these symptoms are following a trauma, such as kind of the world becoming much smaller through avoidance, emotions being very difficult to manage, and feeling very much on edge all of the time. It's understandable that some difficulties will span into mental health challenges. But not everybody will experience post-traumatic stress disorder. And many people will have difficulties that don't fall into that category, but maybe present in other ways. And we know that there are certain things that are protective after a traumatic event to prevent the development of post-traumatic stress responses. So immediately following an event, what we know helps is prioritising self-care. So we know that things like getting back to sleep, eating regularly, getting back into routine, all of these things allow for return to normal functioning. Sleep being very important for helping us to process the events of the day. Avoiding self-medication, such as drugs or alcohol. This is very helpful because the drugs and the alcohol can potentially affect how we process the event and can also maintain some of the avoidance symptoms. And crucially, what is really helpful is social support and attachments. So following an event, using the people around you, so whether that's friends, whether that's family, whether that's professionals, using those people around you is one of the most positive protective factors following a traumatic event. And finally, self-compassion and understanding. So if somebody's experienced something highly traumatic, it is very difficult to cope with all of those symptoms. And I guess even knowing what they are can be very helpful in terms of generating self-compassion. So being able to know that what I'm experiencing is a common trauma reaction. It doesn't mean that I'm changed forever. It doesn't mean that I'm going crazy. This is what most people would experience. Having that understanding can help reduce shame, reduce concern, and self-compassion. So I guess reminding oneself that this is normal and that won't always be this way. So why does this happen? Why do we end up with these symptoms of hyperarousal, intrusive images, and changes to our emotions? Essentially, it comes down to how our brain is processing information at the time. So during a traumatic event, the most important thing for us to do is to be able to survive it. And our brains are very good at helping us to do that. So when we encounter something very stressful, very distressing, very overwhelming, our brain activates a survival mode. So essentially, it recognizes that we're in a threatening or a dangerous situation, and it activates the fight and flight response. So the little part of our brain called the amygdala detects danger, and it sends all the signals to our body to let us know that we need to change something in order to stay safe. So that is increased adrenaline, increased cortisol, getting us ready to survive the situation that we're facing. So what that might feel like is rapid heart rate, tension, blood flowing very quickly to arms and legs, with the idea that perhaps we might be able to escape this situation, or we might be able to fight what it is that we're facing that is very frightening to us. And that's helpful, and that helps us manage the event at that particular time. But whilst our brain is prioritizing survival, it means that it can't do all of the other tasks that our brain would usually be doing. So other parts of our brain, which have other responsibilities, are not working the best way that they need to. So whilst our amygdala is prioritizing our safety and scanning for danger, making sure that we're okay, parts of our brain that help us understand what our emotions are, help us process those, help us put words to our experience, and help us put time and date to what is happening, they get disrupted. And that means that our brain is not fully able to process all of the aspects of the event at that one particular time. Essentially, it's like a filing cabinet, and our brain is unable to make sense of all the information, and it gets shoved in the filing cabinet and the door shut. So our brain is doing the best that it can to process the information in front of us, just to make sure that we survive. Again, very helpful at the time, but creates some other problems later. And also what we know is that once the brain gets activated by trauma, it can get activated in other situations that may have some resemblance to the initial traumatic event. So it may find that our amygdala becomes very sensitive and perhaps reacts to other stimuli in a way that it wouldn't need to. So it's a better safe than sorry type of principle, identifying things that are not threats but are inaccurately being identified as threats. And what that means is that our stress response is being activated very frequently. And there are some effects of that. So if we find ourselves in experiences of a sustained stress response over the long term, it can create further difficulties for us. So having that feeling of adrenaline and cortisol very consistently, feeling that something bad is going to happen, feeling on edge and feeling in fight or flight, not knowing if something bad is around the corner, can create a great sense of anxiety. Depression, digestive problems. So when we're in our fight and flight state, our body wants to make us as lightweight as possible to be able to run away. And so that makes our body want to empty everything that it needs to. And so sometimes our digestive functions aren't prioritized. So digestive difficulties if you have long-term chronic stress responses. Headaches, muscle tension and pain. Risks of heart disease, heart attack, high blood pressure and stroke. So this is for chronic stress responses. Sleep problems, weight gain, and problems with memory and focus. But the age and the stage that trauma takes place is important as well. So if we think that the brain that I showed is an adult brain responding to a traumatic event, how might that differ if we're thinking about a child's brain? So the main difference is that when trauma occurs in childhood, a child is still developing. Brains are very malleable, and children's brains are constantly responding to the information in the environment. So we know that our brain in childhood is being shaped constantly. And children's brains develop essentially from that bottom part up. So if we're thinking the amygdala is the main part and that keeps us all safe, if a child is in a situation where there is kind of chronic, frightening situations, feeling unsafe and as though something bad could happen, then the brain stays in survival mode and the child's safety is prioritized at all times. And what that means is that if a child is developing, then the parts of the brain which go on to control emotions and attachments, and the thinking part of our brain, which helps us reason and rationalize and organize and plan, if a child is spending most of their time in their survival brain, then the other areas of functioning aren't being developed in the same way. So if there is chronic stress, then we would expect to see some difficulties in emotional management for children and behavioural management for children too. And what might that look like if you think of a child who's in a fight or flight state? We might see challenges with attention and concentration. We might see if you've got all that cortisol and all that adrenaline, a lot more restlessness or agitation. If a child is being kind of frightened often, for example, they may not develop the full capacity for maintaining their emotions and developing those like other children may, and effects on personality and self-esteem. But also children are developing their beliefs about themselves. They're developing beliefs about how the world works and how other people are expected to treat them. So if a child is growing up in chronic states of fear or stress, in a child's brain, they may make sense of that by blaming themselves. So they may begin to develop negative views about themselves, perhaps thoughts of being worthless or inadequate. Negative views about the world, maybe thinking that people are against me because there's something about me, and perhaps negative views about the future. So for perhaps thinking something like, I'll never be good at anything. So we can see how when some of these events happen earlier in childhood, a child is being shaped at this time. Has anybody seen this one before? This is the window of tolerance. And so this was developed by Daniel Siegel. And this helps us to understand what happens when we're in kind of chronic stress responses. So if we can imagine that everybody has a window, and within that we function at our best. So we're able to manage daily tasks okay, we're able to manage our emotions, and we're able to withstand a reasonable amount of stress and cope. But what we know is that people who've experienced significant trauma in their life, often their window is much smaller. So let's say other people's is this big, we might have somebody who has a much smaller window. And what that means is that when difficult events happen, whether they're stresses, smaller stresses or larger stresses, it may mean that that person doesn't have that same buffer to manage the emotional reaction that comes with that. So whereas somebody who may have developed the skills to manage intense emotions, they may not be able to do so in the same way. And so what that might look like is alternating between feeling too much and feeling too little. So hyperarousal, feeling very anxious. So this is where we think about feeling too much. Very anxious, very angry, out of control or overwhelmed. And that's a really active fight reaction. Or sometimes it's the very opposite. Feeling very spacey or zoned out or numb or frozen, and the body just wants to shut down. And so for many people, there can be fluctuations between those countless times throughout one day. So things coming along that you feel unable to cope with, and all of a sudden an individual finding themselves at one extreme or the other. So the emotional regulation becoming very challenging over time. So we know that trauma affects the whole body. So if we're thinking about some of the areas that we've talked about before, many people who experience traumatic events don't develop PTSD, so they may not develop the symptoms that I outlined earlier about the intrusive images or the flashbacks, but perhaps there's other stuff happening in the body and in the mind. And so these are further consequences of trauma. So if we start at attention and consciousness. So dissociation is essentially a feeling of being very detached from one's own body and surroundings. So people might describe that as almost like a numbness or a sense of looking at oneself from outside oneself. Amnesia or depersonalization, so perhaps not having full memory for particular events. Emotional regulation, so difficulties in modulating anger and a tendency to self-destruct, or perhaps using self-soothing strategies such as addictions or self-harming behaviours. So we'll come on to think about those in a little bit. Self-perception, so if somebody's been experiencing really difficult events throughout their life, often it can affect the way in which they see themselves. So difficulties get internalized, and perhaps there's a sense of guilt for the individual or shame, or an overwhelming sense of just low self-worth, not feeling good enough, sense of worthlessness. Somatization or medical problems. So some people may experience specific medical problems that might relate to the actual trauma itself, or maybe more diffuse throughout the body. Relationships with others. Relationships are very challenging, particularly if somebody's trauma has been interpersonal. So if it has involved people, it might be challenging to manage other relationships in the future. And I'll think a little bit about that a little further on. But commonly, challenges such as an inability to trust, or inability to feel intimate, or conflict of whether to approach or avoid somebody. So sometimes uncertainty within relationships, and making it very difficult for stability in those. Often feelings of hopelessness, particularly if trauma has been ongoing, or if it's been something which was a big feature in an individual's life. There can be a sense of concern about how things will be in the future, and will anybody ever be able to understand or to help me? And perceptions of the perpetrator, particularly if trauma occurred in childhood. A child absorbs what is being said, and they're making sense of these messages all of the time. So sometimes how others have treated them has become how they treat themselves. So what might some of this look like in daily life? So hypervigilance and overreactivity. So that's the sense of feeling very on edge and anticipating danger at any moment. So the always on moment, making it very hard to relax or feel safe or focus on everyday activities. Again, as mentioned earlier, this is likely to feel like a persistent state of anxiety. So things feeling very dangerous and a sense that anything bad could happen. That will come with some of the physical challenges, such as muscle tension or sleep disturbances. And there's often a startle response. So the body is ready to react at any point to something. And so even small things like a tap on the shoulder, there might be quite a large reaction to that if somebody is feeling very unsafe. Emotional triggers and flashbacks. So when I mentioned the filing cabinet earlier, where everything gets slammed and everything gets shut in there, sometimes things pop out. And memories related to the trauma can happen very unexpectedly. And that can be very overwhelming emotionally, to be going about your day and to find images or memories related to particularly distressing times in your life coming into your mind. And everybody's triggers will be different, and there will be aspects of the particular trauma which stand out and which trigger people individually. Common things such as everyday sounds or smells or images can become triggers. Things like songs on the radio, times of the day, seasons, anniversaries, things on television or movies, things that are on the news. These can all form triggers for people and be very, very difficult. And then the sense of flashbacks and emotional triggers as well can be experienced as though the event is still happening. So when your brain is experiencing one of those events, it can't tell the difference between what was in the past and what is current. So your brain is essentially still reacting as though it's in danger, despite actually being quite safe. Difficulties with memory and concentration. So trauma can make it very difficult to remember information or keep attention on tasks. This can be very frustrating, especially when people are being impacted in work or relationships or in school. And so if we know that people are being affected by imagery or thoughts related to particular events, it's very difficult to remain focused. And if we also think if body is in a kind of chronic stress state, then it's not prioritizing focus on what's in front. Impulsivity and difficulty managing emotions. So again, if our survival brain is in control, then there's not much left over to be able to think about how we're managing our emotions. So emotional regulation can become very challenging. So people might find themselves feeling very out of control. So strong feelings, things like anger or sadness or fear, felt very intensely and often fluctuating from one extreme to another. And that can make people feel very frightened and out of control in themselves. And similarly, again, if our brain is prioritizing safety and survival, then the parts of our brain which are responsible for regulating our behavior, making sure that we're able to think things through before we act, that part is not online either. So we're looking at more kind of impulsive behavior, which can then sometimes lead to further difficulties such as regret for particular behaviors afterwards. Exhaustion and physical health issues. So our survival brain keeps our stress hormones high, and that can lead to fatigue, sleep problems, headaches, other health issues, weaken our immune system, leaving us more prone to developing illnesses. Challenges in relationships, particularly if childhood trauma was interpersonal. So as I touched on earlier, If trauma has been interpersonal, often triggers are interpersonal. So being around other people, perhaps being concerned if you're being judged, if you grew up perhaps where there was abuse, perhaps thinking, is this a safe person to be around? Can I trust them? Triggers might be things like feeling criticised or blamed. And although this may not be anybody's intention, the brain again is very good at looking for threats and will assign threat to people's behaviours. And that can make relationships very challenging, particularly if there's fluctuations in the quality of the relationship at different times. If one person finds themselves feeling rejected or feeling abandoned or feeling isolated, they may withdraw themselves more as a self-protective mechanism, which can create some further challenges. And self-concept, so the ways in which one sees themselves, others and the world. So negative perceptions of the self, things like having really negative thoughts about perhaps I'm worthless, maybe I'm not good enough, maybe there's something shameful about me. So this is kind of a common, these are things that people commonly say following traumatic events, the ways in which their thoughts have been affected. So perhaps thinking thoughts about themselves like I'm incompetent, or regret over particular behaviour, I should have acted differently, or maybe I'm damaged, or maybe this is too much for me to handle. So processing of the event, which places kind of responsibility onto the particular person, and beliefs about the self being changed or damaged over time. Beliefs about the world, often if something very catastrophic and life-changing has happened, and the way in which we expect the world to be no longer feels the same straight after. So our assumptions of how the world would work feels very different, and they've been altered. So it may start to feel like the world is a dangerous place. You know, if this can happen to me, then what else could happen? Is the world unpredictable? Are people dangerous? And maybe I can't trust others. And perhaps views about the future. So concerns about things never being the same, or life changing in a way that will never go back to how it was. Or having thoughts like, what's the point? Or real hopelessness about how things will go. And many of these beliefs have been formed during a very traumatized state, or in childhood formed through a child brain. And so they'll require a lot of revision, a lot of consideration, and a lot of updating through the therapeutic process. So there are many ways that people try and cope following traumatic events. If you think these are all the things going through your mind and this is what's happening emotionally into your body, you know, it's understandable that people do what they can in order to get some respite from that. So common coping strategies which initially set out to be helpful but can sometimes create additional problems. So using drugs or alcohol to block emotional distress, harming oneself. So sometimes, as we touched on with what's happening in our bodies, sometimes the physical state of how our body is feeling can be very overwhelming. So people might rely on ways to calm their body, whether that's drugs or alcohol, whether that's self-harm. Withdrawing from the world and others, so perhaps taking oneself away, trying to be by themselves, taking feelings out on others, whether that's verbal or physical. Controlling eating. So again, if the way that you've understood how the world works has been dramatically altered, and there's been a real perception of things being totally out of control, often a response can be trying to get control over something. And so sometimes that can be controlling eating, which can lead to under-eating through restriction or binging. Having unsafe or unprotected sex, so sometimes that relates to relationship, wishing to feel kind of connected to somebody, or maybe that gives a positive emotions that otherwise aren't there. Avoiding pleasant activities as you think you not deserve them. So commonly, if we're thinking about those beliefs in the last slide about not being kind of good enough, or maybe being shameful or unworthy, perhaps these things feel like something that you don't deserve. And you can see how over time an absence of those could lead to a low mood. Self-blame, common to blame yourself to give yourself a sense of control over what happened. The alternative being that, perhaps bad things can happen. Sometimes placing responsibility or blame onto oneself is a way of kind of rationalising or processing what's happened. Again, being hypervigilant or numbing, shutting off or dissociating from feelings. So again, these are all strategies that are used to try and cope with distress. And often these might be what people seek help for in the first place. So perhaps it's that my relationships are very challenging at the moment and I feel lonely or isolated. I'm finding it very hard to connect. Perhaps it's managing with addiction or self-harm, or the anxiety associated with constant stress response and hypervigilance is overwhelming. Maybe the world is getting smaller through avoidance, or maybe the mood is very low from the thoughts about not being good enough or feeling worthless and withdrawing from positive activities. So often these things start out very helpful and can create further challenges. So what do we do about it? So treating trauma is a phased approach. So we always will start with the phase 1, which is about safety and stabilisation. And that's about establishing safety, managing symptoms, improving emotional regulation, and addressing current stressors. Phase 2 is the specific trauma processing. And phase 3 is reintegration. So re-establishing social and cultural connection and addressing personal quality of life. Essentially, this is what it looks like. So we start at the bottom, always, with prioritising feeling safe. That's emotionally and physically. And it's understandable, often we want to go into the trauma, we want to be able to talk about what's happened and make some meaning from it. But if we think back to that window of tolerance and how challenging it can be to tolerate emotion generally, and how narrow that window is, people might find themselves feeling too much or too little already, then there's a real need to be able to safely broaden that window before we address anything specifically related to the trauma. So working our way up can take some time. So beginning with feeling safe, developing relationships, and that's relationships with counsellors, therapists, psychologists, psychiatrists, whoever it is that you're working with. That can take considerable time, to feel trust, to develop safety and vulnerability in those relationships, and to then be able to open up and think about what it is that has happened to somebody. Allowing oneself to feel the comfort and co-regulation of another person. So allowing somebody else to be there to support you in distressing emotions can be really quite a challenging experience, particularly if people haven't experienced that earlier in their lives, perhaps through neglect. Experiencing empathy and reflection, so being able to connect with emotions, reflect on one's own emotions, all of those things are needed before we go in to exploring trauma. And this can take a considerable amount of time. So phase 1 of trauma is stabilising, and this will be different for everybody depending on what they're currently struggling with. So for example, we would need to be very sure that there's no immediate risk to somebody before progressing with trauma-focused work. So we prioritise the basic things first. So making sure that things like is the person who's accessing the therapy or the intervention going to be in stable accommodation? Are there any big life changes happening to them that could disrupt any of this process? Development of coping skills. So often if people are relying on other behaviours to cope or to tolerate distressing feelings, then there can be a real need to start to develop a range of coping skills. And that might be through other interventions. So it could be through other disciplines. It could be through things like occupational therapy. We could be looking at, grounding exercises, relaxation, engagement in yoga, developing a broad range of skills that will work to be able to connect with the body and calm the body. And skills for tolerating emotional distress. So thinking again back to that window of tolerance, if an individual is experiencing emotional distress And if they find themselves very quickly in hyperarousal or hypoarousal, we need to find a way to give people more time, more of a buffer, so that they don't find themselves in really heightened distress. And various interventions are available for that. But perhaps if somebody has experienced very long-term trauma, particularly in early life, interventions like dialectical behaviour therapy can be recommended, which may address kind of current aspects which could be interfering with somebody's quality of life at that time. Perhaps stabilising means addressing co-occurring conditions. So perhaps that means addressing an anxiety disorder, if that's happening alongside a PTSD or another trauma reaction, or depression. So if there's a depression that is very overwhelming, or there's suicidality, for example, it's in somebody's best interest to make sure that we have improvement in those symptoms before moving forward into anything else. So stabilising problematic drug or alcohol use. So if there's kind of an addiction issue or self-medication or self-soothing through drugs or alcohol, then we need to do our best to stabilise that. Again, it's about thinking about the safety, how well somebody would be able to manage the distress caused when you get into processing the details of the traumatic events. We want to make sure that people are kind of free of behaviours which cause additional distress afterwards. And eliminating or reducing self-injurious behaviour, so things like self-harm. And again, this can take a very long time, and it's different for everybody. So often people want to get there, and people want to have this part done to be able to go through the trauma themselves, and it can often feel frustrating, I suppose, to be told to wait and to work on this resourcing part first. But I guess this is part one. Trauma treatment includes stabilisation, and this is a foundation of going on to having any further focused therapy. And there's also the element of readiness. So perhaps we've worked through all of these things. An individual has developed a range of coping skills. Things are feeling really stable. Any other co-occurring conditions are being treated appropriately. But perhaps there's other life changes happening, and perhaps this isn't the best time to be addressing trauma. So it's important that whoever it is that is considering the trauma therapy is thinking about the time in their life and how much work and emotional toll this type of intervention can take as well. So really making an informed choice about, is this now? And for some people, this might be enough for a period of time, and then maybe down the line at another point in life, people may then choose to address the trauma specifically. So again, I've referenced another book here, Recovering from Trauma Using Compassion-Focused Therapy. So developing a compassionate relationship with oneself, really a core part of the stabilisation. And then we move on to the trauma-focused treatment itself. So kind of like the filing cabinet, if we think about during a traumatic event, our memories get stored in the wardrobe. So really thrown in, door slammed, just to help us bypass that immediate distress. But then the door is bursting open and everything is coming out at different times. So again, that's our kind of flashbacks or memories or reminders. So what trauma therapy specifically does is it helps us get some control and some organisation over these memories and events. So that involves kind of taking everything out and having a good look at what's in there. So the things that perhaps we have pushed to the back of our mind, consciously or unconsciously. Trauma therapy involves going through a lot of this and making sense of it, updating perhaps the meaning that we made on it, and just making sure that the conclusions that we come to now are the ones that kind of serve us best. And there's different interventions that are available. So from the evidence base, those which are recommended for children and adults are trauma-focused cognitive behavioural therapy. So that will focus on addressing behaviours and thoughts and feelings related to the trauma. So it will work on addressing features like the avoidance, so perhaps working towards, engaging in the difficult memories associated, whether that is behavioural avoidance, so it might be kind of going back to places where traumatic events occurred, or whether it is addressing mental avoidance through exposure, which basically means going through the details of what it is that happened. The idea being that in doing so, better able to make sense of things, manage the emotions associated, and get better understanding over time. So looking at the meaning that was made at that particular time and seeing are there other ways that we could look at that situation now. Other intervention recommended for children and adults is eye movement desensitization and reprocessing, called EMDR, which is another intervention which really focuses on the connection between the mind and body. So recognizing that there's this huge bodily reaction that we have after a traumatic event. EMDR works by allowing the emotions to come up, and the eye movement part essentially is asking an individual to move their glance in a particular way, which essentially kind of places some distraction on memory, meaning that the memory from the trauma can come up, but it's actually able to be processed in a different way without an individual becoming extremely overwhelmed. There are other interventions. So these are the focused interventions for trauma and those which are most recommended. And that research comes from studies of people who have reached particular diagnostic criteria for like PTSD or complex PTSD. But not everybody will have those diagnoses, and there's much more common traumas which don't fall into those categories. So other interventions that are out there, so things like compassion-focused therapy is really beneficial for helping you to, connect in a way that is free from self-criticism and more compassionate in the way that we speak to ourselves. So compassion-focused therapy, other interventions called like schema therapy, sensory motor psychotherapy. So it's really, there's a broad range of therapies out there which can help. And finally, so we know that a lot of people who experience traumatic events don't go on to develop PTSD and maybe go on to have a set of complex emotional or behavioural responses. But there's also positive that can come as well. So post-traumatic growth refers to positive psychological changes experienced as a result of a struggle with trauma or highly challenging situations. So post-traumatic growth may feature positive changes in self-perception, interpersonal relationships and philosophy of life, leading to increased self-awareness and self-confidence, an open attitude towards others, or a greater appreciation of life and the discovering of new possibilities. So post-traumatic growth recognises that the events themselves are devastating, distressing, overwhelming, but often through all of that, positives can come. So sometimes that is people having fresh perspectives on life, new ways of looking at the world, investment or engagement with relationships or prioritization of physical health. So there are a range of positives which can come to following trauma. Okay, so that is that. Thank you. Thank you.
Thank you, Louise. I think I can safely say that there's plenty of fodder for thought in what Louise has offered us this evening. A really very thorough overview of a very, complex area. But I hope that some of the elements of what Louise has brought have tweaked your interest and caught your attention. What we usually do at this point is just take a few minutes of a breather and a break to allow you the opportunity to gather your thoughts, and if you have a particular question that you'd like to bring forward, you can pass that along to any of us who are around in the room. The ladies will help, and Louise and myself, if you want to pass the question on. We've gotten some questions that were submitted by people who are attending online, and so they were able to submit a question in advance. So don't feel pressured to ask a question, because I'm sure what they've asked will mirror a lot of the questions in the room. But we do welcome them, and we'll try and cluster the questions into broad themes so that we're touching the base of as many areas as possible that might come up. The quality of questions that have come through here, they certainly have given us food for thought back, which is always one of the really interesting parts of this process. So thanks to everybody who submitted questions. And what we plan to do is talk through some of our thoughts about those, because I'm not sure we have absolute or definitive answers, because I think as Louise has shown us, the area of trauma really is a very intricate weave of how life experiences can coalesce in a certain way that make things challenging for us and that catch us into traumatic responses. So to kick off with some of the questions, how do you explain trauma to someone who's never thought about it in psychological terms before? I know that our presentation tonight probably was coming from quite a psychological perspective with psychological theory. But, you know, I think one of the most accessible definitions of trauma that I've heard is that it's like a wound that never fully heals and that can weep again if it's unaddressed. So life can throw up all sorts of experiences to us. It can put us off our feet at times. It can upend our best laid plans. And for some of us, that can cause an upheaval and an upset that runs to our core. And if we've experienced that at different points in our lives, then the newest experience can be all the more challenging. And a gradual build-up and a repetition of challenging experience can bring us to a point where our reaction is compromised, our ability to cope is compromised, our resilience is compromised, and we can be worn down, not just by the most recent episode, but by the way different episodes have played out for us. And I think that's what trauma is. And I think one of the other quotes around trauma that stays with me is that trauma isn't our fault. Trauma, it's not down to us choosing to experience things in a certain way. Trauma is the stuff of life that very often is way beyond our control. But it is our responsibility to try and manage that and to heal and to grow. And that can be challenging and that can be painful. And I'm conscious that one of the next questions that came in was how or what advice would you give to somebody who is hesitant or afraid to begin trauma-focused therapy? And maybe would you like to talk to that?
Yeah. I suppose after thinking through all the challenges that we talked through in the presentation there, the first thing I'd say is it's understandable to feel cautious about going into this type of work. Often this stuff is buried very deep, particularly if it's old stuff or childhood stuff. There can be great fear about what it would mean to even bring this stuff up now, to be afraid of how you might cope if you're to start something at this perhaps a different stage in your life. So the fear is normal, but I'd also wonder, what happens without addressing it? There might be some distress that is being experienced already, and is it worth perhaps giving the time to unpacking what's caused that distress in the first place? Knowing that it's hard work and potentially can be long work, but knowing also, I think when people understand that there is that phased approach and that you're in control of it really, you're in control of the trauma therapy, you can stop at stabilisation, you feel well resourced, you feel safe, that can be enough. All of this is about safety and trust and not moving too quickly until somebody is ready. So I think putting the control into somebody else's hands, especially if they've experienced loss of control before, I'd say that would be therapeutic in itself.
Yeah, I think the whole issue of building a trusting relationship with somebody is really important in terms of trying to I suppose, support someone to recognize the meaning that's in their own story, to be able to identify that actually we're talking about trauma here. Because I would say, and I'm sure you would have the same experience, Louise, the number of people who begin to talk about their lives and say, you know, I've had a fairly uneventful life, it's grand, you know, normal upbringing, no, nothing out of the way. And I say, gosh, that's great. What was it like, or who was around? And we start to delve into it a little bit more. And the story that unfolds is one that's filled with trauma. But the person doesn't see it from that lens because their survival, their safety has demanded that they keep that under wraps, that they don't go to the trauma. Now, it would be an abuse for anyone in the name of therapy to go and say, oh, well, now you've got trauma and you have to do a lot of work. We sit with it and we work with wherever somebody's at and listen a little bit more and encourage and try to help them to build that resourcefulness, that resilience again. And in time, they will move towards it at their own pace. So how do we support, which was one of the questions, how do we support somebody who's not there? We support, we listen, we encourage, we resource, but we never shove or push, because that's going to be re-traumatizing. And this is why this kind of therapy can take quite a long while. And this is why, you know, very often we'd see here in the hospital that people may present with really challenging mental health needs that are on a foundation of trauma. And to support somebody to arrive at a point where they can be back at home, where they can go back to work, where they can be among their friends, that's a really positive step forward. And in time, they may then go a little bit further and begin to do some of the trauma work. But when they're ready and when they're resourced and when the base is kind of in place. Is it possible to experience trauma without being fully aware of it at the time? I guess we kind of covered that, haven't we? Can everyday stress or burnout ever be considered traumatic, or is there a clear line between stress and trauma?
Yeah, that's a good question. There's similarity really in our responses. If we think that it's called a stress response, you know, so we're experiencing stress on a daily basis, but there are differences between daily stress and trauma, and some of the main parts are that the subjective experience, so feeling very frightened, feeling as though you're in danger. They're some of the things that would separate out kind of stress and burnout from trauma. However, if you're somebody who has experienced a lot of trauma already or adversity, and then you're faced with additional stress later on, perhaps the ability to be able to manage that is depleted. If we go back again to thinking about the window of tolerance model, you know, your window is getting narrower and narrower perhaps, so perhaps stress is encountered as in the same way as a traumatic event would be. The brain is experiencing it in that way, and so the responses are quite similar. So, but a lot of the interventions in the stabilization phase are similar to what you'd be recommending, I suppose, for managing stress as well. So they're about your grounding, your relaxation, getting the kind of basics under control, developing self-compassion, all of those interventions. I guess there's an overlap between stress and trauma in that sense.
And we've had a couple of questions that talked about diagnosis and the very real dilemma that exists for people who work in the area to differentiate between different conditions. And there's a reality where something that may look like a particular mental health disorder or personality disorder can mirror many of the symptoms of trauma. So you end up in a situation where, you know, is it one or is it the other? And that can be quite a conflictual dynamic to arrive at. So for example, is something a personality disorder or is it complex PTSD? And I think the value of clinical diagnosis is to try to streamline what the presentation that somebody brings into a language or into a conceptual base that people can have a shared understanding of. That's really the big value in terms of having diagnosis in this area. And I think very often it can be helpful to have somebody with a personality diagnosis because that allows access and open into relevant therapies that would be appropriate. But yes, of course, you know, we would see all the time that somebody who presents with a personality disorder has a foundation of trauma. And while we might be helping them to understand, and Louise referred to this in her talk, where we might refer somebody to dialectical behavior therapy, which is for a personality disorder, that would be a first line intervention in terms of helping them to build resilience and coping and resourcefulness in the here and now, so that they can go on and do further, maybe deeper trauma-related therapy down the line. So diagnoses are important, they're helpful, but may not be a perfect descriptor all the time as to what exactly is going on for somebody because of the complexity of all of this and because of the nuances of all of this. But if they serve as a way of helping people to understand themselves and to avail of different structured supports along the way of their recovery, then it's a really helpful piece that we have.
When I hear particular diagnoses, it helps me organise in my mind perhaps what might be beneficial for somebody in perhaps a first meeting or an initial assessment. But then beyond that, it's not thinking, you know, what's the diagnosis or what is the label that you have. It's thinking, you know, what has happened to you and what experiences have you had that mean that you're struggling in this way. So the diagnosis is useful for organising and directing, but we get kind of much further into the individual experience, then we can identify what's the most useful intervention for this person at this time.
A nice question here. For someone who wants to support a friend or loved one who's been through trauma, what are helpful ways to do that, especially when you don't want to say the wrong thing? You know, I think we probably all have a fear of saying the wrong thing. Nobody more so than myself in the therapy room at times. I think there's a golden rule about saying the wrong thing, and it's important to bear it in mind. If we say the wrong thing, as we will, we're human, we're not perfect, we don't get all the variables all the time, and we may find ourselves putting the left foot right into the middle of it. The greatest words we can say after that are, geez, I'm sorry, I got that wrong. Explain to me what's happening here for you. Help me understand. And you can do the best recovery ever and probably deepen your capacity to support somebody. So don't ever be afraid of saying the wrong thing. If you're talking to somebody and coming from a place of wanting to help them, you're going to be on a good enough footing, and you can recover if you blurt something that doesn't hit the spot. But what can you do? I think time to listen, to validate somebody's experience, to encourage. You know, you might be full of helpful suggestions. What have you do this? Have you tried that? I know somebody who did the other. Maybe hold back on that and go back to the listen, support, encourage, be there, be warm, lots of nodding. Questions if you have to ask, not about the detail of what's going on for them, as much as what was it like for you? How are you now? Where are you at? Can I help? All the stuff that comes instinctually to us. And I think it's about just trusting yourself and going with your own instinct as a friend, as a parent, as a neighbor, whatever it is. That will guide you in terms of what you can offer by way of support. You don't have to be the expert. All you have to do is just be the person in the role that you are. Is it a friend? Is it a neighbor? Is it a colleague? Whatever. And trust that and go with it. And if you get it wrong, I'm sorry. I really didn't want to upset you. Help me to understand what it is you need. Want to add anything to that?
I couldn't add anything to that.
Okay. How can people rebuild a sense of safety and control when their trust and stability has been shaken by trauma?
Yeah, it's interesting because it's really what happens after trauma is the sense of knowing things as you used to know them, feeling very different. And I guess it's about that self-compassion, knowing that this is a process that's going to take some time, being kind to yourself and not judging yourself throughout that process. It takes time to feel, as I mentioned, most people will take a couple of weeks really to start to feel more like themselves, but it can take quite a long time. And I'd say it's taking small steps, dipping your toe into things that perhaps you've noticed yourself pull back from and seeing how it feels, seeing how you tolerate it. Does this feel okay? Is this too much for me? And gradually kind of building these things up over time, because it's often fear that is holding us back from getting back to the life that, was most valuable for us. And so not being held back by fear and being gentle with ourselves in the steps that we do take.
What are some of the most common myths you hear about trauma therapy, and how do you address them? I suppose some of the myths are that this is going to be awful. I'm going to have to relive this and get into it, and I'm going to have to tell it over and over and over and over again. That's probably one of the biggest concerns that I certainly hear from people who talk, if we're considering what therapy might be helpful for trauma. And that is a myth. It's not necessarily about going through the event and repeating it and parsing it and looking at it from every possible angle. Because remember, the core work is about helping somebody to be grounded in the moment, to be safe, to be able to exist in the present moment rather than being pulled into the past. So a lot of the focus of trauma therapy will be about the resourcing and the resilience building. But even within the core trauma-focused work, very often it's not necessarily about the telling of the story. And the processing might be about giving somebody the space to, without anything being named, and there's a method blind to therapist approach to particular parts of the therapy, where someone can effectively process experiences without actually naming what the experience they're working on is. It may seem a little bizarre to say that, but actually it can be a really productive way of doing therapy. And it's very helpful where there's sexual trauma or where there's something that's particularly violent that somebody might not want to be naming and going through in an overt way. So trauma therapy, in essence, must be very gentle, must be very supportive, must be very mindful of helping the person to stay in the here and now, as opposed to getting sucked back into the events that have caused them difficulty. Because if that happens, all we're doing is facilitating re-traumatizing people. So for us as therapists, our responsibility is to make sure that it's a safe process and not one that drags people needlessly through the horrors of their life experiences again. We have a question here that kind of zones in on hypersexuality as a response to sexual trauma. But I wonder, we might broaden it out because I think it can relate to a number of different areas. The types of responses, and you touched on it in the talk, Louise, the types of the ways people might act out or demonstrate the trauma in their lived experience currently, be that through sexualized behaviors, through addictive behaviors, or would you have any comment on that?
Yeah, when I saw this question, instinctively I thought, is this a child or an adult? I wasn't sure, and I think it's important to know what age and stage a sexual trauma has taken place, because then we think about, you know, what part of development perhaps was interrupted by that sexual abuse. And so it's not uncommon to see kind of hypersexualized behaviors following childhood sexual abuse in children particularly. And then, you know, that can be about lots of different things. Maybe that's about connection. Maybe that helps people feel good. You know, that's the way that a child has learnt particular feelings for themselves. And sometimes when children get older, these behaviours can stick around. But there's often much more. There's often, I guess, something about feeling connected or wanted. Maybe it gives that emotional, like I kind of touched on earlier, maybe if there's an emptiness or a feeling that is intolerable, maybe this is something which alters that feeling and creates a different emotional state. And perhaps feeling very connected to somebody for a short period of time is a very validating or a very comforting experience for someone who's experienced sexual trauma. But it's complex, and I suppose a trajectory from sexual trauma into hypersexuality is quite nuanced, and yeah, would require a little more thought, I would think, yeah.
So, with all of that, we might begin to call it a night. But I do want to thank all of you for coming along, for taking time out of your evening to be with us, whether that's here in person or the many people that have joined us online tonight, which is a really good development for these series, to be able to broaden it into people being able to visit us from home. We've enjoyed, well, I certainly have enjoyed the topic and presenting. I think it's always good to be able to ply our trade and to share some of the rationale for how we operate as we do. And I know Louise has brought the intricacies of that to your attention tonight. I hope you've enjoyed it as much as I have. I hope you've enjoyed her competence and her skill and experience as much as I continue to do all the time that I work with her. So thank you once again, Louise, for all your effort. And if I might just leave you with a final wee thought. Both of us started tonight with encouragement that you mind yourself. And I have no doubt that as our conversation has flowed here tonight, that for each one of us, something will have gone through our mind, some connection where we might have said, oh, I wonder, is that what goes on for so-and-so? Or, oh, maybe that's what goes on for me. And these are important thoughts. And I would encourage you to really just honor them and to mind yourself. And let's all send a lot of love and a lot of good intentions to anybody that has crossed your mind tonight, and to each of us who are present here as we continue on this journey of life that we're privileged to be living. So do mind yourselves and go home safely. Thank you.